Good morning to everyone. We are going to present, so we see a lot of interstitial lung disease in our practice. It is one of the largest centers we have as a referral center, Department of Pulmonary Medicine, SGPGI in Lucknow. It's one of the largest referral bases. So we started noticing that there is a lot of change in the terminologies over the last 2-3 years. New guidelines have come up. Management has changed depending on the behavioral phenotype of the disease. Now we are not classifying the disease only by the pathology or the histopathology report, but how the disease is behaving phenotypically. So when we came across these findings, we started collecting data and find out what is actually happening with our patients. And we're going to apprise everybody about this condition per se, fibrosing interstitial lung diseases, and what's happening as their outcomes in our setup. So for presenter, we have Dr. Rishu Chatterjee. He is our second year DM fellow, and he'll be presenting the CGR now.
Very good morning to you all. I'm Dr. Rishu from Department of Pulmonary Medicine, presenting today's CGR on fibrosing interstitial lung diseases. Interstitial lung diseases are broad heterogeneous group of lung parenchymal disorders. It is also known as DPLD or diffuse parenchymal lung diseases. Pathogenetic sequence is characterized by varying degrees of inflammation and fibrosis involving the pulmonary interstitial bed as well as lung parenchyma. So there occur fibroblast and myofibroblastic proliferation, extracellular matrix deposition, followed by alveolar septal thickening and fibrosis. So interstitial lung diseases, it not only involve just interstitium. It can involve the alveolus, it can involve the airways, the lung parenchyma, and subsequently the pulmonary vasculature. So there may be organizing pneumonia pattern, respiratory bronchiolitis pattern, and hypersensitivity pneumonitis also. So the broad term is diffuse parenchymal lung diseases. With more than 200 disorders under the umbrella, majority of interstitial lung disease are still classified as rare. Early and accurate diagnosis can be challenging, especially in resource-limited settings. ILDs include several diseases of unknown etiologies, as well as some ILDs known to be related to other diseases, such as connective tissue disease related, or due to environmental, occupational, or drug exposures. Now, this is a global prevalence study of interstitial lung diseases done in 2021 to assess the global trends of interstitial lung disease in different countries. And there was significant heterogeneity noted in the incidence and prevalence of ILDs between different countries, largely attributable to the diversity of the underlying population, use of different diagnostic algorithm, and differences in different data source that was used. So there are different Indian studies as well that also that were done to assess incidence and prevalence of ILDs and different subgroups. Different retrospective and prospective studies were done. Among all, there was a study which Singh et al. Include 1084 patients, and it shows that there was 47.3% patients were found to have chronic HP, followed by around 13% patient have of idiopathic pulmonary fibrosis. Now, prevalence and attributable health burden of chronic respiratory disease from 1990 to 2017, a systematic analysis to assess the global burden of disease. It was done, and it shows that prevalence of ILDs shows increasing trend. Globally, around 30% increase were there. Southeast Asian belt, there was 100% increase was noted. Interstitial lung diseases and pulmonary sarcoidosis were found to be more prevalent among males than among females. So the next question is that why there is rising prevalence of ILDs in most of the part of the world? The most important point is that there is a long duration of the disease. It is a chronic debilitating condition with a gradual onset, poor cure rates despite newer therapies like antifibrotics and lung transplantation. There is increase in incident cases, that is increase in risk factors like age, environmental and occupational exposures, increased awareness among clinicians and physicians because there is early referral to advanced care centers. Better diagnostic approaches are there like lung cryobiopsies, Hertz-guided lung biopsies, and early detection is going on, especially at the level of interstitial lung anomalies, and we are having quantitative CT analysis also. So what is making ILD difficult to manage? So there is confusing terminologies, complex pathobiology, variable patterns and natural history of the disease, substantial time lag to clinical diagnosis, and variable with an unpredictable course, whether sometimes may be fibrosing, sometimes progressive, and often very disappointing treatment outcomes is there. So historically, interstitial lung disease were given different nomenclature. In 1800th century, Ramazini has given that is a disease of grain workers. Subsequently, different nomenclature was given, and from the year 2000 onwards, definite guidelines were started implementing on different types of interstitial lung disease. And from 2000 to 2021, we found ATS ERS definite guidelines describing different patterns of ILDs like IPF, IIPs, hypersensitivity pneumonitis, sarcoidosis, along with their diagnostic strategies and treatment algorithm. Now coming to overview of ILD classification. The first broad group is IIP, that is idiopathic interstitial pneumonia, which includes major IIP like idiopathic pulmonary fibrosis, idiopathic NSIP, respiratory bronchiolitis related ILD, discommutative interstitial pneumonia, cryptogenic organizing pneumonia, and acute interstitial pneumonia. Some rare IIP like idiopathic lymphoid interstitial pneumonia, idiopathic pleuroparenchymal fibroelastosis, and unclassifiable. Next broad group is the granulomatous ILDs that includes sarcoidosis, hypersensitivity pneumonitis, borreliosis. ILD with known causes, that is autoimmune ILDs that include CTD associated or IPAF. Exposure-related ILDs like occupational exposure, environmental exposure, avocational, and drug-induced. And other group, that is a miscellaneous group that includes lymphangioliomyomatosis, pulmonary Langerhans cell lymphocytosis, vasculitis, diffuse alveolar hemorrhage, and neurofibromatosis. So these are the broad groups of ILD classification. Now, diagnosis of interstitial lung disease, usually it is a multidisciplinary approach. First, evaluation includes assessment of clinical presentation. Often that is non-specific and overlapping. Specific history assessment. What drugs patient is taking, what is the occupational history, what is the exposure history, and whether patient is having any smoking history or not. Followed by, we have to do lung functional evaluation by spirometry DLCO, serological test assessment, especially of autoimmune markers, assessment of lung radiology by chest imaging with CT chest, and sometimes lung biopsy in some selected cases. High resolution CT chest, it is considered as a primary tool for accurate diagnosis of interstitial lung disease, looking for signs of fibrotic disease. HRCT can also help determining the prognosis, evaluating the disease progression, and diagnosing any associated complications. Now, coming to different common HRCT findings that we usually encounter in different inflammatory varieties of ILD, that is not usually fibrotic. Most common is the ground glass opacities. Number 2 is interlobular septal thickening, and inter and intra, both septal thickening, followed by traction bronchiectasis and areas of consolidation. So these are the characteristic radiological findings we find in inflammatory varieties of ILD. Now, HRCT chest findings that designates an fibrotic ILD pattern. The most important is honeycombing. So honeycombing is characterized by presence of clustered cystic spaces with well-defined shared walls measuring about 2 to 10 millimeter in diameter, sometimes reaching around 25 millimeter, and usually they are present in the subpleural region. It may be associated with other findings of fibrosis like intralobular reticulation, presence of traction bronchiectasis or bronchiolectasis, loss of lower lung volume, and fissural and architectural lung distortion. So these are the findings that can recognize a fibrotic ILD pattern on HRCT chest. Idiopathic pulmonary fibrosis or IPF, it is considered the prototype variety of fibrosing ILDs, and most of the cases it is very progressive in nature. So IPF, the prototype pattern is definite UIP pattern. So this definite UIP pattern, it is usually characterized by presence of bilateral basal subpleural honeycombing with reticular opacities, traction bronchiectasis, loss of lung volume, and significant distortion of the lung architecture. So if this definite UIP pattern is present, it is usually signifies that is IPF. And ATS-ERS guidelines, it has also recommends that IPF can be confidently diagnosed if there is clinical evaluation of the patient points towards IPF, and as well as if there is radiological finding, HRCT showing a definite or probable UIP pattern. So we can confidently stamp it as idiopathic pulmonary fibrosis. Now coming to the next HRCT pattern, that is called probable UIP. It is usually characterized by presence of traction bronchiectasis or bronchiolectasis, reticular opacities, mild GGOs in peripheral subpleural distribution, and usually there is absence of honeycombing. So probable UIP, there will be no honeycombing. Now coming to next variety, that is called indeterminate for UIP. Usually HRCT shows diffuse distribution, ground glass opacities superimposed with fine reticular pattern, subtend reticular abnormalities, no subpleural predominance, and it was often associated with nodules, emphysema, cyst, mosaic attenuation, areas of organizing pneumonia, and others. And this indeterminate UIP, it should be evaluated further by subsequent discussion. Other common patterns that we see in HRCT chest is called NSIP pattern. It is characterized by symmetrical and bilateral GGOs, usually lower lobe predominant, fine reticulation, volume loss with areas of traction bronchiectasis, and immediate subpleural sparing. Other radiological findings on HRCT, it is called peribronchovascular involvement. There may be mosaic attenuation, areas of air trapping, reticulation, traction bronchiectasis with presence of associated nodules or cyst. So these are the different patterns that we can encounter in radiology. So why it is very much needed to classify interstitial lung disease? Because pattern of ILDs, respect to clinical radiological presentation, its natural history and prognosis, it varies among different subgroup and subtypes. So classification that was used earlier is an etiology-based classification. What is the merit? In particular for ILDs that are managed by removing the underlying cause. If we know the etiology, we can manage it by removing the underlying cause directly, like smoking-related ILD, drug-induced, or exposure-related hypersensitivity pneumonitis. It has limitation that we can miss the idiopathic conditions and similar phenotypes can be missed. Now, current classification that we are dealing regularly in our practice, it is an face-to-face multidisciplinary discussion among clinicians, radiologists, and pathologists coming to a working or definite diagnosis of ILD. Upcoming classification or the classification that is going on also, that is called behavioral-based and mechanism-based approach to classify ILDs that are being actively explored in the last decade. For example, many ILDs, it has a chronic fibrotic presentation, which may be sometimes progressive over time. So behavioral-based and mechanism-based approach is of great interest in nowadays. So this chart is also describing various pattern of classification of ILDs. We have already discussed that previously. We have etiology-based classification. Day-to-day, now we are in day-to-day practice doing multidisciplinary discussion between clinician, pathologist, and radiologist. And there is also most important, that is behavioral-based and mechanism-based classification to assess the disease nature and progression of ILDs. Now, why it is very much important to assess the disease behavior rather than classification of subtypes? Because most of them are having a common molecular pathways and a common genetic abnormalities. So assessment of disease progression and disease behavior is very important to a clinician. And how it can be done? It can be done by assessment of worsening of symptom status, whether there is worsening of baseline cough or dyspnea, assessment of quality of life, whether there is any deterioration of health-related quality of life, whether there is any decrease in physical function, like decrease in exercise capacity, decrease in lung functional status, especially declining in PFT parameters like FVC and DLCO, radiological assessment on HRCT chest, whether there is any increase in extent of radiological abnormalities, and global impression of the patient and the subject, whether the disease has worsened or not. And obviously, if there is acute exacerbation and acute worsening of respiratory function, it is also considered to be a disease progression. So assessment of disease behavior and disease progression, it is very important for a clinician to assess the treatment and further outcome assessment. So the next very important concept in ILD, that is called PF-ILD, or called progressive fibrosing ILD. PF-ILD is recently used to describe a subset of ILD patients who have inexorable progression of pulmonary fibrosis despite treatment, have underlying pathogenetic mechanism and clinical behaviors like idiopathic pulmonary fibrosis. Non-IPF PF-ILDs, it usually includes NSIP, unclassifiable IIPs, chronic HP, autoimmune ILDs, sarcoidosis, and exposure-related lung diseases. Although it's rare, proportion of PF-ILD, it has been estimated around 20 to 40% in initial studies, and based on the different definition that was used. Now, in a study done in Europe in 2022 by Hilbert et al., it shows that PF behavior, progressive fibrosing behavior with UIP-like pattern, that were present in around 30% case of non-IPF ILD cases each. And hypersensitivity pneumonitis was shown the highest percentage of this progressive behavior, around 50%, followed by unclassifiable ILD, that was around 45%. In another European study in 2021 October, in a single center study of around 400 patients with non-IPF fibrosing ILDs, it was found that 34% of patients, it shows a progressive phenotype and a very poor outcome similar to that of IPF, regardless of the diagnostic criteria that was used. So PF-ILD, this data were there in different studies. So there are different definitions that can be used in defining PF-ILD. The most important is the Cotton's definition, that's called COPF-ILD, that are coming in the subsequent slides. Other classifications may be relief PF-ILD definition, inbuilt PF-ILD classification, UILD definitions. So there are different definition and diagnostic criteria for PF-ILD, among which Cotton's classification is considered most useful, and we are using it in day-to-day practice. Now, PF-ILD, how it is defined? It is defined by presence of following criteria. There is relative decline in FVC of more than 10%, or a relative decline in DLCO of more than is equal to 15%, or a relative decline in FVC of more than is equal to 5%, but less than 10%, in combination with worsening of respiratory symptoms and radiological findings on HRCT chest in past 24 months. This is the Cotton's criteria for diagnosis PF-ILD that we are using in our practice. Now, regarding PF-ILD, what are the things that are known to us? That is, PF-ILD has a common pathogenetic mechanisms, self-sustaining fibrosis, declining in lung function, worsening dyspnea, deterioration of quality of life, and subsequently early mortality. These are the things that we are already known. But what are the parameters, or what are the things that we are not known regarding PF-ILD still now? That what are the markers or predictors of disease progression? Which patient should we select for initiation of treatment? What is the role of immunosuppression in this patient? What is the role of antifibrotic therapy? Assessment of treatment response in this patient, and validated patient-reported outcomes. So these are the things that we should in a research panel. Now, in a study by Chenx et al., it shows that survival of PF-ILD in a Kaplan-Meier curve of 132 patient, it reveals that 1, 3, and 5-year survival was around 90.9, 59%, and 49% around respectively. Prognosis was found to be as similar to that of IPF patient, while it was worse than non-IPF PF-ILD cases. And it was found that extent of fibrotic changes on HRCT chest and pulmonary artery hypertension was found to be the two great important predictors for mortality assessment. Now, coming to our departmental experience in a study that we have conducted about fibrosing interstitial lung diseases. The Department of Pulmonary Medicine is running a dedicated and successful interstitial lung disease clinic on outpatient basis since many years. Over the years, it has become one of the largest referral centers in Uttar Pradesh for patients of ILD. There has been a consistent increase in the number of ILD patients referred to us, along with an ongoing pool of regular follow-up of patients. In view of the recent advances in diagnostics, classification and management of ILDs, an observational follow-up study was conducted in our department, including this fibrosing ILDs. So what was our study population? We included all adult patients diagnosed as a case of fibrosing ILD between 2014 to 2017 in the Department of Pulmonary Medicine after doing multidisciplinary discussion. The study was approved by Ethical Clearance Committee and informed consent was waived due to the retrospective design. Clinical and survival data were retrospectively obtained from the medical records, telephonic interviews, or prospectively collected during follow-up visits of the patients. Now, this was our approach to these patients of fibrosing ILD that we have included. First, we did comprehensive evaluation by proper clinical assessment, that is history and clinical examination, assessment of lung functional status by PFT and DLCO, radiological assessment with HRCT chest, serological tests of autoimmune markers, and we did BAL study if it is considered in selected cases. Followed by we did a multidisciplinary discussion between clinicians, pathologists, and radiologists, MDD, to obtain a diagnosis of a given entity or a working diagnosis of an entity that is a provisional diagnosis, or it was stamped as unclassifiable ILD. BAL study or biopsy, if it is required, it was done in selected cases after MDD. So after this MDD, we put the patients either in treatment or kept in wait and watch. And also subsequently, we monitored these patients for disease progression on follow-up. We did it by clinical assessment, serial pulmonary function tests monitoring, and follow-up HRCT test every 6 months. Patients whose clinical and radiological or functional status worsening with disease progression, they consider to be as PF-ILD. No disease progression, they consider to be a variety of non-PF ILDs. So this was the strategy we have taken during our study. So our study flowchart includes that fibrosing ILD that was diagnosed in pulmonary medicine in our department after MDD between 2014 to 17, there was 355 patients, among which 155 patients were excluded from the study because of loss of medical records, non-compliance with the treatment, loss to follow-up, and some COVID-related complications or death were there. So total 200 patients were included, that was fibrosing ILDs, were having a regular follow-up of at least 5 years or till their death. And we, in our results, we found that survivors at the end of 5 years, it was around 148 patients, and expired patients before 5 years was 52. Now, coming to our breakup of ILD patients, fibrosing ILD patients that were included in our study, the breakup shows that sarcoidosis group was the most common fibrosing ILD, that is around 27.5%, followed by autoimmune ILDs, that was 23%. Followed by there was NSIP, chronic HP, and IPF cases. Now, assessment of demographic parameters. In our study, we found that male is to female ratio is 9:11. That is, female patients were more in our study. But predominance of male patients were found in IPF group. And most of the patients were attended were from the urban background. 60% of the patients were from urban background. Now, regarding age and BMI, we found that median age of population was 53.5 years. Highest age, around 63 years, was found in IPF group, and lowest was found in sarcoidosis group, that was around 44 years. Median BMI was highest in the sarcoidosis group, followed by autoimmune ILD group, autoimmune ILD group, and IPF group. And the miscellaneous group that had the lowest BMI among all these patients. Now, coming to assessment of clinical presentation. Now, on evaluation, we found that progressive exertional dyspnea and dry cough It was the most common symptoms and it was significantly present in all the subtypes. Smoking exposure was significantly associated with idiopathic pulmonary fibrosis and miscellaneous ILD. Clubbing was predominantly seen in IPF group in around 24% of cases. Now, assessment of comorbidities. Regarding comorbidities, we found that, interestingly, GERD, it is most frequently and most commonly associated comorbidity in all other, most of the subtypes. Most frequently, it was associated, complicating the disease course, followed by systemic hypertension and diabetes mellitus. Now, coming to HRCT chest assessment. Regarding HRCT findings, we found that honeycombing, it was predominantly seen in IPF group, around 100% of the cases, followed by chronic HP, around 61% of cases. Presence of ground glass opacities and mediastinal lymphadenopathy was the commonest HRCT finding in sarcoidosis group, followed by autoimmune ILD group. Mosaic attenuation, it was predominantly observed in chronic HP and sarcoidosis group. So these are the radiological on HRCT chest. Coming to assessment of lung functional parameters. We have done PFT, that in PFT parameters with FVC and FEV1. We did DLCO. We have taken baseline SpO2 assessment and 6-minute walk distance in meters. We found that median value of FVC percentage, FEV1 and DLCO, that was lowest in idiopathic pulmonary fibrosis group, followed by NSIP and chronic HP group. Sarcoidosis group, it shows highest median value of functional pulmonary function parameters. And 6-minute walk distance, it was found to be lowest in IPF group, followed by chronic HP group. So these are the functional parameters that we have assessed. Now coming to role of other diagnostic modalities in establishing diagnosis of ILDs. So we did autoimmune assessment of ANA, RA, ENA, ANCA, BAL and lung biopsies in selected cases. And we found that ANA positivity was significantly seen in autoimmune ILDs, that in around 98% cases. But it was also found to be positive in around 22% cases of chronic HP, around 25.4% cases of sarcoidosis also. Biopsy was found to be yielding around 36% cases of NSIP, around 35 cases of chronic HP, and around 18.21% cases of sarcoidosis. Now coming to assessment of outcomes regarding survival probability of different subgroups of this ILD patient. In the Kaplan-Meier curve, it was showed that there was total survival was 148 patients, death was 52 patients. We followed for 60 months regarding the survival assessment. We found that the graph is showing that IPF patient, they have the lowest survival, followed by miscellaneous group. Then there was chronic HP group. Best outcome was seen in NSIP and sarcoidosis group regarding survival. So assessment of outcome survival, we found that IPF patients, they have the lowest mean survival, around 41.68 months. Better survival outcome was seen in autoimmune ILD group, that is around 55.78 months mean value, and sarcoidosis group, that was in 57.6 months. So that was better outcome was seen in this group compared to IPF group regarding survival. Now coming to classification of PF-ILD patients in our study. In our study, there were 80 patients was having PF-ILD, that is around 40%, and 60% was non-PF-ILD. Proportion of PF-ILD in different subtypes, it was around 37% cases of autoimmune ILD was PF-ILD, 70.58% of cases of IPF was found to be progressive in nature, 32.14% was NSIP, around 35% of chronic HP, around 33% of sarcoidosis, and around 4% of miscellaneous group. They showed a progressive nature and they were considered as PF-ILD in our study. Now, assessment of survival in PF-ILD groups. Total deaths was 52 among 200 patients, that is on 26%. Proportion of PF-ILD patients that was expired, that was 47 out of 200, that is around 23.5%. And deaths in PF-ILD group, it was 47 out of 80, around 58.8%. So it was clear that death and survival outcome was considered very poor in case of PF-ILD rather than non-PF group. Now, coming to the comparison of various parameters between survivors and non-survivors, predicting survivors and non-survivors. Regarding clinical assessment and symptom assessment, we found that presence of fever and clubbing, it was found to be statistically significant in differentiating between the survival and the death outcome in patients in included ILD patients. Regarding assessment of comorbidities, it was found that presence of congestive heart failure, COPD, history of exposure to smoking, and biomass fuel. That was the parameters that was found to be statistically significant regarding assessment of surviving and non-surviving in patients of this in the included study. Regarding HRCT chest assessment, we found that presence of cysts and emphysema, presence of honeycombing, and extent of fibrosis on chest radiology. These are the three very important statistically significant parameters that we have found on statistical analysis that can differentiate between the outcome regarding surviving and non-survivors in included fibrosing ILD cases. Now, on statistical analysis, we found that the continuous variables that was found to be statistically significant regarding assessment of outcome regarding death or survival, that age in years, BMI, symptom duration in months, CCIP, that is Charlson Comorbidity Index points, mean pulmonary artery pressure on millimeter of mercury, FEV1 and FVC percentage of DLCO, baseline SpO2 percentage, and 6-minute walk distance in meter. So these are the parameters we found statistically significant. These are the continuous variables we found statistically significant that can predict the outcome regarding survival and mortality. So on multivariate analysis, we found that the most important predictors of mortality in our study, that is CCIP, that is Charlson Comorbidity Index points, 6-minute walk distance, presence of honeycombing in HRCT chest, and whether it is a PF-ILD or not. These are the most important significant factors with an odds ratio of more than 1 that can predict mortality of fibrosing ILD patients. Now, coming to summary and conclusion, fibrosing ILD is a subset of interstitial lung disease with a challenging course in terms of diagnosis, management, prognosis, and outcomes. Progressive fibrosis is a self-sustaining and an important characteristic of several fibrosing ILDs that is strongly linked with morbidity and mortality. There is no consensus as how disease progression should be defined in patients with ILDs. But in clinical practice, it is typically assessed through assessment of lung function, clinical assessment of symptoms and signs, and HRCT chest to see the progression of radiological findings. In our study, we have highlighted that there is very high prevalence of PF-ILD, progressive fibrosing ILD, in Indian patients. It was found to be around 40%, and 30 to 35% in also in non-IPF ILD group. Outcome remains always very poor in fibrosing ILDs with progressive phenotype in terms of symptoms, pulmonary functions, quality of life, and need for hospitalization. It is also associated with very high morbidity and mortality, which is also evident in our study that around 60% of mortality was noticed in PF-ILD group. So what are the key points that should be kept in our mind regarding management of these fibrosing ILDs? The most important is teamwork, dedicated centers of expertise, early accurate diagnosis, rational approach to management with guidelines-based strategies, strict monitoring for progression of disease, response to therapies, especially to antifibrotics and rehabilitation, and early listing and referral of this patient for lung transplantation. Thank you.